Brilliant. Hello, everybody. Welcome to LIV TB. Another month has rolled on. October here. It's a bit dingy in the UK, entering mid-autumn. And so James is here. James Seddon is here to brighten up our lives a little bit, which is great. Tell us about MDR-TB in children. I thought that ideally we'll go round and just introduce ourselves briefly, and if you could put your video on if you're happy to, and just tell us a little bit about you and who you are, where you're from, that'd be really nice. And I think then we'll start with James's talk probably by about 20 to 1 British summertime. So I'll start us off, and then I'll go round because I can see all your names up there. I'm Tom. I'm one of the senior clinical lecturers here at Liverpool School of Tropical Medicine. I work at the Royal Liverpool Hospital as well for nearly half of my time, and I'm interested in addressing the social determinants and consequences of tuberculosis. So then if we can go to, and James, we'll come to you last because you're speaking today, okay? Umar Khan, next, please. If you're able to, Umar. Okay, let's go. So, Aaron Koenig.
Yes, hello, my name is Aaron Koenig. I'm from the United States, and I'm taking one of the tropical medicine courses.
Great, thank you very much. Then Callum, I've got next, Callum Semple. Hi, Callum. We've got Daniel Hernandez.
Yeah, hi. Former LSTM student and currently working for MSF with DRTB patients.
Thank you. Charlotte Buxbaum. Hey, Charlotte, I think you're talking. Can't hear you there, Charlotte, sorry. Charlotte, we'll come back to you. Donna Fleming. Hi, Donna.
Oh, hi. My name's Donna Fleming. I'm one of the TB nurses at East Lancashire, and I was just joining out of interest today to see what was going on.
Great, lovely to have you. Mustafa Al Said.
Oh, hi, my name is Mustafa Al Said. I'm a consultant in infectious diseases and medical microbiology, Royal United Hospitals in Bath.
Thank you. Flaminia Sabrier.
Yes, I'm Flaminia. I work for MSF, and in particular on projects where there are pediatric TB children.
Thank you. Then we've got Gemma Skellen.
Hi, I'm Gemma. I'm one of the students on the Global Health course at the School of Tropical Medicine.
Thanks for joining, Gemma. Tom Gorsuch.
Hi, Tom. I'm Tom Gorsuch. I'm a respiratory consultant in Manchester and TB specialist here. I also do HIV.
Thank you, James. I can see you, James Millard.
Hi, I'm ID Reg in London at George's. Interested in MDR-TB, but not in children, in adults. So I'm hoping to understand more about children.
Me too. Jay Achar, who I was just speaking to earlier this morning again. Hi, Jay.
Yeah, hi, Tom. I'm Jay Archer. I'm an ID specialist based in Stockholm in Sweden, and also James's PhD student.
Okay, excellent. Nadia, my co-lead here, Nadia Contagiani. Hi.
Hi, Tom, and hi, everybody. I'm Nadia Contagiani. I'm a research technician working on TB tuberculosis research the last years in LSTM and having a great interest on MDR-TB.
Thanks, Nadia. And you've got Nyasha Mafira Kareva.
Hi, everyone. My name is Nyasha. I'm currently working as a health economist at the University of Sheffield. My work currently involves evaluating pediatric TB interventions. Thank you.
Thanks, Nyasha. Nice to hear your voice again. Pete Dodd.
Hi, I'm a modeler and epidemiologist based at the University of Sheffield.
Brilliant. Thanks, Pete. And then we've got Sarah, followed by Sven. Sarah first. I don't know if you can speak, Sarah.
Hello, can you hear me?
I can hear you well.
Okay, fantastic. So I am a health protection practitioner from UK Health Security Agency, and I'm just learning more about TB today.
Great to have you. Sven.
Yes, Sven Hoffner. I'm a senior researcher at Global Public Health, Karolinska Institute, Stockholm.
Thank you very much, Sven. And I see, Uma, I know you can't speak. I can see from your microphone, but thanks very much for coming. Okay, brilliant. Great to have you all here, and a big welcome to James Seddon, and thanks for coming to speak to us. I see you've got a satellite talk as well next week at the Union meeting, James. James works at the Imperial College London in Stellenbosch University. And amongst the many different things he's going to do, James is going to give us an overview today of MDR, TB in children, which I think all of us, whether we're adult physicians or paediatric physicians or in public health, are really looking forward to hearing. So James, please, over to you. Take it away.
Thanks very, very much. And thanks for the kind invite to come and talk to you. So I'm going to talk a bit about what's going on with MDR TB in children. This is not going to be a kind of clinical guide to how to diagnose and treat children with MDR TB. That's kind of quite a different type of talk. But I'm going to talk about where we are really almost with the research landscape with MDR TB, and mainly with the treatment rather than the diagnostics, because diagnostics is quite similar in some ways to drug susceptible TB, and that's a whole different field as well. As was mentioned, yeah, I'm kind of employed by Imperial, but I live and work in Cape Town, and I do my research mostly in Cape Town, where I'm speaking to from now. And what I'm going to try and cover over kind of the next half hour is talk a little bit about the burden of MDR TB, and then treatment and our changing understanding of the treatment of MDR TB disease in children, and then a bit about MDR TB infection. So that's kind of the remit I'm going to go for. So I think the first thing when we're talking about burden is to think about, why do we need to know burden? Why do we need to know how many children have TB globally, let alone MDR TB? Well, I think we need to know who's getting TB and where they are and when they are, because it's only by doing that that you can really allocate resources appropriately. You can also look at discrepancies between the number who have been diagnosed and the number you're expecting to be diagnosed. There's also this kind of concept in child TB that children are a sentinel event, because they can only have been exposed to TB and progressed to disease within their short life. They are a marker of disease transmission. So if there's a lot of child TB, it suggests that there's a lot of circulating strain. So it's really a window onto the wider epidemic. So having a clue on what's going on in child TB is important for the wider TB burden. I think to engage anyone from the corporate sector, either pharmaceuticals or diagnostics companies, to think about developing a product, we need to know how many people have it. And also from advocacy for resources, both for programmatic work and for research, we need to know how many people have it. And this is the famous pie of death. This is the pie that is produced by every few years, the documents under 5 mortality. And there are about 6 million children die in the world each year under 5. A lot of them, over a third, are neonates, so under 28 days, and the rest are from 1 month to 60 months. And as you can see on this pie, this is what drives a huge amount of funding, both on a programmatic level and also a research level. And as you can see from this, TB is not represented. If you think there are 6 million deaths, 10% of that would be 600,000, 1% would be 60,000. So if you're coming up on this pie with a 1% slice of the deaths, that's about 60,000, and at the moment TB is not represented on this. So why don't we know how many children get TB? Well, it's actually quite difficult to confirm TB in children, because they don't carefully cough into a pot for you and that you can take and put in an expert machine or look in a microscope. You have to do kind of induced sputum or gastric aspirates or other procedures. Children also have what's termed porcibacillary disease. So the pathophysiology of TB in children means they don't have that many bugs in their body. So even if you do get a specimen, often it's negative. And generally the places that you want to have really good culture and expert and molecular technologies to diagnose TB is often where those aren't available, often where TB is present in children. And really the biggest challenges in diagnostics are the youngest children, and those are the burden where TB there's the most TB in the youngest children. And not only is it difficult to confirm this diagnosis, but also reporting has traditionally not been great. So if you go back 10 years, 15 years, only smear positive cases were really reported with any confidence, and often the private sector didn't get involved. Data were not disaggregated very well, and also a lot of the data was hidden in other disease burdens. And so you have this pie chart where you think there is a certain burden of children with TB out there. Only some of them will make it to health services, which again, as kind of program people and academics, there's not a lot you can do about. Although I think increasing advocacy, increasing training and education can work with this. And then they do present to health services, and some of them are diagnosed, and this is a diagnostic question. And then of those who are diagnosed and start on treatment, only a proportion of those get reported WHO. So there are gaps at every stage. And so this was something that Pete and I did, getting on for 10 years ago nearly, where we thought that the WHO approaches to estimating the burden of TB in children were inadequate, because they took an approach that looked at the number that had reported cases. So they said, well, how many pediatric TB cases have been diagnosed and started treatment and reported to us from each country in the world? We will inflate them by a kind of underdiagnosis kind of factor. And they came up for the first time in 2012 with an estimate of about 500,000 children developing TB, and we felt that was likely to be an underdiagnosis. So we took more of a natural history approach, starting with the number of children in each country who might be at risk, and then taking models of exposure to work out how many children might develop TB infection, and then propagating that based on the age and the effect of BCG vaccination, HRG, to think about how many of those each year would progress to disease and what kind of disease, and came up with an estimate of disease through this, which was about 1 million children a year. And not that surprisingly, the places where there's a lot of TB in children are places where there's a lot of children and a lot of TB. But what's interesting, I think, from the violin plot on the right, which looks at the dots are the actual notifications by that country, by that year for that age group, and the violin is the estimate from our model. And you can see that there are a few, I think, quite interesting things about this. First of all, is the dots are further to the left in the youngest children, so we're seeing like worse reporting, worse diagnosis compared to our estimates in the youngest children. The other thing is, I think, the huge heterogeneity between countries. So it's not a pattern that just everywhere they're underdiagnosing and underreporting. Some countries seem to be quite similar to the estimates. You look at places like Indonesia or Brazil, not bad compared to what we estimate. And the other pattern I think you can see is that it's worst in the youngest children. I've already mentioned that. Okay, what about drug resistance? So I think probably everyone on this call knows that MDR-TB is defined as disease caused by a bug that is resistant to isoniazid and rifampicin. And the old definition of XDR-TB was MDR with additional resistance to fluoroquinolones and the injectables, and that's been revised to include with the injectables being less relevant. But still, we have the concept that MDR is these first two powerful drugs, and XDR is just worse TB with more second-line drug resistance. So how many children have MDR-TB in the world? Well, again, it's a function of several things superimposed on each other. It's a function of how many children are in a country. So this is a map cartogram looking at where each country is represented by the number of children in it. So you can see where all the children in the world are. It's also represented by how much TB there is in a country, and this is from our estimates of child TB, looking at where is all the TB. But then you also need to think about what proportion of TB is drug resistant. So you need to know how many children there are, how much TB there is in children, and then what proportion of that is drug resistance. And again, another really important factor is well, because we don't have much good microbiological data from children, if we just look at routine data about drug resistance, confirmed drug resistance in children, there's really a sparsity of data. But this nice review tried to say, well, if you take new cases in adults where there's lots of data, and the few studies which have looked at microbiology confirmed TB in children, what proportion of drug resistance in the two. And what this study found is obviously there's variability, but generally there's about the same proportion. So if you have 100 cases of TB in adults in one time and place, and 10 of them are MDR, and you have 100 children with TB, generally 10 of those are going to be MDR as well. And that's an important relationship, because it's not obvious that is the case, but it does mean that then if you can use that to model child proportions if you know adult proportions, because trying to start with child proportions is going to be very sparse data. So again, this is the second modelling study that Pete and I did a few years later, which tried to divide TB in different types, different categories, so RIF mono-resistant, isoniazid mono, and then the sort of subcategories of resistance to fluoroquinolones and injectable agents. And Pete did some interesting sampling where, for the countries where we had good estimates of first and second line drug resistance in new adult TB cases, we would use those data. But if those data weren't brilliant from the WHO, we would sample from nearest neighbours, assuming they would have not dissimilar epidemiology, or sampling from regional averages, so that we then had a proportion of TB for every country in the world that had drug susceptible, rifampicin mono-resistant, MDR, isoniazid mono, and then each of the subdivisions of further resistance as well. So we had an estimate with uncertainty for each country in new adult cases, and we then would superimpose that on top of our estimates of child TB burden to come up with estimates of MDR TB in children. And so what we came up with really is that there were just over 800,000 children totally who got TB. As I said, it's just under 1 million, and of those about 25,000 who had MDR, which pure MDR, just 18,000, and then all the subdivisions after that. And a substantial proportion of children had drug-resistant TB and drug-resistant TB infection. So nearly 2 million children have MDR TB infection. And when you look at these images on the left-hand side, you have these are drug-susceptible TB is the red dots, and then the different first-line drug resistances with the others. And you can see in the Europe region quite high levels of MDR as a proportion of all TB. So these are really proportions. And then the right-hand plot is looking of those who are MDR, what proportion are, it's labeled as drug susceptible, that's pure MDR with no further resistance. And then you look at the other colours to show which are fluoroquinolone resistant, second line injectable resistance, and XDR. So you can see the different regions of the world have different proportions of these. And so globally, the estimate, as I said, summarising, is about 25,000, and other group at similar time estimates about 30,000. And this is substantially more than children are being treated. A very small number of children are being treated. But what's, I think, exciting is that over the last 10 years, the landscape has changed dramatically. And really, there was almost no interest in child TB, or no interest in understanding child TB burden, even 10 years ago. And then pretty much year on year, there's been substantial improvements in our understanding, in several modelling studies that us and other groups have done, and these are then being incorporated into global guidance. And really, the last WHO report, which was from 2020, real step change into moving forward to disaggregate data in children into 5-year age bands, which people in the child TB community have been really pushing for a long time, as well as asking for data in those ways and disaggregating it into drug susceptible and drug resistance. So this was from last year's report. You're seeing for the first time, and you can see these dots are the first time they've ever estimated adolescent TB, the first time they've ever estimated some of these other groupings of disease. So we will have, going forward, asking for countries to produce data in these formats, and also looking at notifications by MDR and rifampicin resistant TB. So 3,300 in 2018, and then 5,500 children. And if we think that there are maybe 30,000 children who have, or 25, 30,000, we're only picking up a relatively 20% of children with MDR TB getting diagnosed and treated, and child TB, MDR TB is only about 3.5% of all TB in children. But this is a massive, massive improvement from where we were 10 years ago. And I think all of us in the child TB community are really excited to see that countries are being asked to produce data in a way that actually allows this kind of granularity and allows us to sort of dissect the program and dissect things in far more detail. Okay, so I think that's improved our understanding of the burden of MDR-TB in children. I'm going to move now on to the treatment of how we treat MDR-TB disease. And this was the first, I think, effort to try and bring together some of the data on child MDR treatment. There have been a very, very small number of case reports that had been published when we did this review 10 years ago. And it brought together, you know, a few hundred children. I think there were 300 children who in the medical literature had ever been treated for MDR-TB 10 years ago. And we tried to bring these together to look at treatment outcomes, and we saw the outcomes were actually very good, 80% successful outcome, which at the time in adults it was about 40% favourable outcome for MDR-TB. But just the tiny numbers were really concerning, that there was almost no evidence in the literature as what this, you know, to how to treat children with MDR-TB. And so a group of us went through and tried to do an individual patient systematic review. This was done a few years later and compiled about 1,000 children, so a really stepwise improvement. And by collecting individual patient data, they could be interrogated far more rigorously. And you can see from this map that the data came really from all over the world. Quite a lot from South Africa, but again, other countries really contributing data that was very useful to begin to understand the different ways of treating MDR-TB. And what you see here is actually, again, a very strong pattern that outcomes are very good. If a child is diagnosed and started on treatment for MDR, outcomes are very good. And you see that in confirmed disease, which was the majority of this cohort at this time, you were getting 92% favourable outcome. In the clinically diagnosed patients, you're getting 95%. And these findings were incorporated into the 2016 guideline, which really advocated children being started on MDR-TB treatment clinically when they had clinically diagnosed disease and been exposed to an MDR source case. They should be started on treatment. It also advocated for regimens that didn't use injectables and used all oral regimens and could be used for shorter durations. And because a lot of these children had been treated for shorter durations and had very successful outcomes, there was a push in this 2016 guideline and said it wasn't necessary to treat children the same way at that time that adults were being treated with 6 months of an injectable and about 18 to 24 months total therapy. So I think that this kind of synthesis of data helped the WHO make appropriate guidelines. But the guidance for children generally has been quite outdated. This guideline was published in 2014, so 6 or 7 years ago now. And WHO this year felt it was really important to update their guideline and have gone through a process of developing a whole new child TB guideline this year. Will be published by the end of this year. And they set out to have about 10 different PICO questions. The PICO questions cover the treatment of TB meningitis, diagnostics, how to best to use diagnostic algorithms, how best to obtain samples for microbiological diagnostics. It had stuff on adolescence. It had material on a whole range of elements for child TB management, and including shorter treatment for drug susceptible TB, in line with the SHINE guide trial that's just been published. But one big part of this was on MDR-TB. And WHO wanted, or child TB guidelines wanted to update their guidelines. And so we embarked on another individual patient systematic review. And this time we got data from about 25,000 children being treated for MDR-TB. So you can see the changes over the last 10 years have gone from 300 children in the entire medical literature in a systematic review done 10 years ago to 1,000 in a systematic review done about 4 or 5 years ago, and then this most recent systematic review, 25,000 children. And a lot of this is programmatic data; it's not published data, but still, there's been a huge change in the number of children globally being treated for MDR-TB. And the guideline development group met in June, July, and they appraised the evidence from this 25,000 children. They also looked at the primary trial results from particularly bedaquiline and delamanid, which are 2 drugs which many of you have heard of, which are new drugs, but actually not that new for adults. Been using them for about 10 years, but haven't really been used very extensively in children, and there have been age limitations in how we use them. So up until this year, we've been advised that we can't use delamanid in children younger than 3 years old, and we can't use bedaquiline in children younger than 6-year-old because we didn't have adequate safety data and we didn't have appropriate formulations to use. But as this guideline process that was released a couple of weeks ago, this rapid communication. The full guideline will come out at the end of the year, but in the rapid communication, the guidelines on review of this evidence from the individual patient data and the safety data from the trials really said there was no signal that that these drugs were unsafe. And it's a huge thing for us in the paediatric community to be able to now use bedaquiline and dilamidin for any child. So we can use now these drugs from any child from any age. And we acknowledge that the number of children being treated in those youngest age bands, the under 5-year-olds, it is quite limited. But in some ways, that's always been the case, and until we start treating them, we're not going to have great data. So I think that this is a huge step forward, and it means that we can move away from using nasty, unpleasant injectable drugs with poor efficacy and high toxicity into giving the most effective drugs to all children that are safe and probably have a high chance of successful outcome. But what about the right combination of drugs? So I think we've now in a position where in kids we can use all kinds of, we can pretty much use all the drugs you can use in adults, maybe not protominid, but all the other ones we can now use in kids. So we're based with this armory, but what combination, how long, what dosages? Well, there's a huge amount of interest, and this slide is probably a bit out of date, but there's a lot of studies going on in the adult world to evaluate different types of regimen. But actually, almost all of these studies either had a cutoff at 18 or they included some older adolescents, but really very few children have been included in any of these clinical trials. So although, yes, you can extrapolate if you find a regimen seems to be effective in adults, you can probably say it works in children, but children are quite different. They have a different spectrum of disease. They have different side effect profiles sometimes, and you probably need very different dosing. And so we do need primary studies to look at drug combinations, not just individual drugs in children. And hopefully later this year, or probably more likely early next year, a clinical trial, phase 2 trial, which is really a safety and dosing study will be done, which will take children with MDR-TB and will give them a standardized oral regimen for 6 months, which will give 2 months of linezolid and with fluoroquinolone, bedaquiline, and dilamidin. So in some ways, giving what in many of the adult study they give protominid and bedaquiline together, whereas this is giving dilamidin, bedaquiline, linezolid, and then stopping the linezolid after 2 months and continuing for a total of 6 months with a strong background regimen of a fluoroquinolone, bedaquiline, and dilamidin. And those who have fluoroquinolone resistance will substitute clofazimine for the fluoroquinolone. And I think that this study, which has been approved by the US Impact Network, by the NIH, for multiple sites throughout the world, should be able to recruit fairly quickly. And I think if we have these data, I think this would give everyone, if this combines with adult studies that come out and say these short 6-month regimens with good new drugs are adequate, and we have some data in children, I think this should become the standard norm of care. The idea of giving 12, 18 months treatment hopefully will be a thing of the past when we have these good regimens using newest drugs. So what about TB infection? Well, I think I probably don't need to tell this audience that TB is a complicated disease where you breathe in the bug, and most people don't ever get sick with it, and quite a lot will, though, have a bug somewhere in their body that elicits an immune response that can be identified with an IGRA test or a TST, a tuberculous skin test, which show this picture in the middle. And many people with TB infection will never progress to disease, but some people will progress to disease, and this is the X-ray on the right. It's a picture of miliary disease. It's disseminated disease in a young child, very nasty kind of disease. And so we know that some people with infection will go on to get disease, and so in the past we increasingly advocate giving preventive therapy, a kind of drug therapy, to people who have been exposed to or have evidence of infection to prevent them going on to get disease. And so you have this continuum from exposure to infection to disease, mortality, and the theory is if you give people therapy who have infection, you prevent them going on to get disease. And we've been doing this for 60 years, and it works very effectively. We had the first data was using isoniazid, and then increasingly we're using rifamycin, rifampicin on its own, or rifampicin and isoniazid, and increasingly rifapentin to provide. And there's good evidence that this works. However, what do we do when the source case has drug-resistant TB, where the isolate is resistant to rifampicin and isoniazid, which are really the two classes that we have good evidence for? A systematic review done a couple of years ago looked at the very, very patchy and very thin and somewhat questionable data that had been done in 5 or 6 studies which had been observational. So these observational studies had either taken cohorts of children and adults who'd been exposed to MDR-TB and either not treated them or treated all of them or treated some of them but not others. None of them were trials, so none of them were randomized. But there did seem to be a pattern from these studies that treatment with some kind of MDR preventive therapy where the regimen is designed so that it's giving drugs that the source case isolate is susceptible does reduce the risk. So this risk reduction is very impressive. 0.1 is a 90% reduction of risk. And in the sort of, but this is very patchy data to take a cohort of untreated patients from one country and a cohort of patients from a different country at a different time and treat them and try and compare those is very questionable. So I think what we desperately need is clinical trials to evaluate this. And at the moment, there are 3 clinical trials underway which are trying to evaluate whether you can give a drug to prevent MDR-TB. So there's the TB CHAMP trial, which is one I'm involved in, which is 3 sites in South Africa. And it has up until just now been just recruiting children under 5, but the protocol version 3 has been approved, and in the next week or so we're going to start also recruiting 5 to 18-year-olds who have a positive IGRA test in addition to the under 5s, irrespective of IGRA status. There's the Phoenix trial, which is a massive ACTG US-funded trial in multiple sites, which is comparing isoniazid with delamanid as preventive therapy, and they're taking children and then anyone over 5 who's got a positive IGRA. This is going to be a huge trial, costing a lot of money and will run for several years. And then there's the VQuIN trial, which is in Vietnam, led by Vietnamese investigators and Australian investigators. And this is a big trial which has finished recruitment. They're also comparing levofloxacin with placebo. And they are looking at, it's mainly adults they managed to recruit. They have recruited some children, but for various logistic and procedural reasons, they haven't included many children. But they have finished recruitment and they're following up early next year. So the results of that trial will be the first out that will be with us probably next year. So TB CHAMP, which is the trial that I know best, is in 3 sites in South Africa. And we're actually about to expand to 2 more sites as well to increase recruitment. We're looking at children and under 5 and soon to be older children who have been exposed to adult MDR case in their household. And we're looking to recruit about 1,000 children. We've recruited just short of 800 at the moment. And they're randomized to the intervention arm, which is daily levofloxacin for 6 months or daily placebo for 6 months. So it's double-blinded. Both participants and staff don't know. And the primary outcome is incident TB disease or death by 1 year after starting the interventional regimen. And this will give us, I think, really good data on safety. We'll have 500 children have been treated rigorously with levofloxacin, and we'll be able to see what the adverse events are and compare them to children who are not receiving any drug. And I think that kind of noise often clouds observational studies because children have all kinds of things happen to them that cause rash or cough or side effects that we need to account for. And we'll have some data on efficacy. I think we are finding we'll probably be quite underpowered because we've only had a relatively modest number of endpoints so far in the trial. We might be underpowered for efficacy, but I think this will be a very useful. We will probably stop recruitment at the end of June next year and follow all patients up till the end of December next year. So we're expecting to release the results of this trial in early 2023. So as I mentioned, we're probably going to be a bit underpowered, and from talking to the VQuIN trial team, they're also probably going to be a little bit underpowered to demonstrate their primary efficacy endpoint because they also have had fewer endpoints than they expected. Obviously, if all the endpoints were in the placebo group, then that might still be sufficiently powered. And so we've been talking already about pooling analyses between these 2 trials. They're obviously different populations, they're different countries, one's in children, one's predominantly in adults, but they are the same regimen. So we're giving levofloxacin versus placebo. And we've also been talking about not only doing a pooled analysis, a traditional kind of meta-analysis, but also a Bayesian form of analysis where we will have an adjusted analysis from VQuIN, which borrows information from the results from TB CHAMP, and vice versa. We'll have an estimate of effect size for TB CHAMP by borrowing some data from VQuIN. And we've been talking to statisticians at the MRC Clinical Trials Unit in London who have some expertise in doing this, and we'll be setting up some preliminary work to generate some priors for this ahead of the results from VQuin coming out. So probably VQuin will publish their results early next year, and then a year later CHAMP will publish their results, and hopefully very soon after that we'll have the combined results coming out together. So within TB Champ, we are doing a lot of sub-studies. So these are my little symbols that are supposed to represent lots of things. So for those of you who probably can't decipher my hieroglyphics, we're doing a lot of health economic work. So this has been mainly led by Tommy Wilkinson, looking at the cost of MDR preventive therapy. We're also costing MDR TB treatment in children from the health system perspective and also the patient perspective. We're looking at quality of life in these children, and we're also looking at socioeconomic status. And then once we have the trial results, we'll be able to really populate the cost of treating and the cost of not treating and compare and be able to do a proper cost effectiveness. We've done quite a lot of pharmacokinetics. That's the top right image of this new, we've developed this trial actually paid for the development of a new formulation of levofloxacin for the trial, which has been developed by McLeod's, which is available on the Global Drug Facility. So hopefully programs will be able to use this, and we've done some PK work on this. We have done a lot of socio-behavioral work around acceptability of formulations, about understanding of preventive therapy and risk. And we've done a lot of acceptability work on the new formulations, which is my Leotard diagram in the bottom. We work very closely with the microbiologists at Stellenbosch, and we're doing quite a lot looking at microbiome and how that's altered by levofloxacin, and also just looking at the microbiome of healthy children in the communities where we work. We're, in addition to looking at the microbiome, we're looking at the frequency of drug-resistant non-TB bacteria in the gut of children to see how commonly children in these contexts have other gram-negative organisms and even gram-positives in their stool, and look at how commonly those are resistant to a range of antibiotics, but particularly the fluoroquinolones at the beginning of therapy and then at the end of therapy. Because although showing a reduction in TB risk is important, if we're causing untold damage outside this to antimicrobial resistance, this clearly needs to be factored in when we're making decisions about whether this is a useful thing to implement. And the final element, which I'm going to talk about a bit more, is some of the biomarker work we've been doing as part of TB Champ. So as I explained, if you do have this continuum, and if you can treat children with infection, you can prevent disease, hopefully, but we actually are treating most children with infection don't go on to get disease. So we're actually treating a lot of children for infection to prevent each case, and we're treating a lot of children unnecessarily. So if you could predict which children were going to progress through infection disease, this would obviously be an improvement. And if you look at studies that have, or reviews that have tried to quantify how many people you have to treat to prevent a case, well, actually, numbers needed to treat for children with a positive IGRA and TST are very large. So, the current tests we have are really inadequate. Their positive predicted values are very poor, and the numbers needed to treat are very high. And so if we could develop some kind of test which was much better at predicting the risk of progression to disease in the future, we would be able to target our preventive therapy at those who actually need it the most, and hopefully you'd be able to increase uptake and reduce adverse events. And this was a nice study done in adults, which I'm sure many of you have seen, led by a whole bunch of people, actually a huge consortium, big study where they took 6,000 adolescents who were IGRA positive, and they followed them up for a couple of years, and many of them, or some of them, went on to get TB disease. So you can see the left-hand side of this figure here, where they're all green, they were all healthy at this point, and they followed them up, and various of them became TB positive, which is the red, at various time points. And then they realigned these patient time points, so the disease was already at the same time point. They went back at samples that were taken every 6 months to look at, and they did RNA sequencing on these samples that were taken and stored, and then they compared adolescents who had gone on to get disease to adolescents who had remained healthy. So you compare the progressors to the non-progressors to try and identify which genes are activated in those who are progressing disease. Ideally, the small number of genes that could then be developed into a point-of-care test that could say, yes, in the next 6 months, the next 12 months, you have quite a high risk of going on to get disease, versus no, in the next year or so, you have quite a low risk. If you could reduce that to a very small number of genes, then that could be translated into a point-of-care test. And they found a signature which was not bad at predicting risk of progression within the next only really 6 to 12 months. Going out longer than that was not so great. So we're going to really try and repeat this within TB Champ. So we are collecting PAX gene tubes in all children at baseline and every 2 months on treatment. And then ultimately we are expecting in the placebo arm, some children will go on to get disease and most won't. And we'll take the cases, either children are going to get disease, and we will take 2 controls for each case. And then we'll allocate a training and a test set within this. We'll use the training set to look at differential expression of genes to see which genes are different between the cases and controls, and then we'll use some measure of principal component or variable selection to reduce this to a small number of transcripts that are the best at discriminating the cases from the controls. And then we'll test that in the test set, and then try and reduce it into a very small number that we can translate into a PCR-based test that we could then use to make clinical decisions. In addition to using these gene expression studies to identify tests, small number of transcripts to use tests, you can also feed the whole number of differentially expressed transcripts into the kind of software which can then map out immunological pathways, so you can begin to understand the biology of what is different about a child who's about to get disease from those who are going on to get well, which pathways are up and down activated, which metabolic and immunological bits of their cellular mechanisms are different, and then that might help you either design vaccines that might prevent this from happening, or to give some kind of host-directed therapy that might blunt these or reduce these. So understanding the biology is also equally important as developing tests that discriminate. And this is another, I think, very interesting study that was done by several people at the London School and at Imperial, where this was done in adults, where a bunch of adults who were IGRA positive were treated for TB. This drug susceptible adults were, or adults who'd been exposed to drug susceptible TB and were IGRA positive, and they were treated with a drug susceptible preventive therapy regimen. And they had their RNA sequencing, they had blood sequenced at various time points after doing that. And then they had a cohort of IGRA negative patients who really had no TB exposure, and they also were given preventive therapy and seen what happened to their transcript. And what was interesting about this is IGRA positivity really only reflects immunological memory of having seen TB at some point. It doesn't tell you whether they're viable bacilli in the body, and many people increasingly think that a lot of people who are IGRA positive actually have cleared the bugs. There are no bugs there, so there's no real risk of disease progression. So in this study, what they found is that about half of the IGRA positive patients clustered with the IGRA negative when they looked at gene expression, and then the other half clustered away in a very separate grouping. And what their hypothesis is that that maybe those half who are IGRA positive clustered with the IGRA negative might not have viable bacilli, and so you're not detecting bacillary death when you give preventive therapy. You're not seeing a change because you're not killing anything because there's nothing there. And so if you could use this, you might then be able to either identify a signature at baseline that that means that you've got viable bacilli, or you could give a very short treatment, and if there's no change in that signature after a couple of days or even a week of therapy, you might say, okay, there were no bacilli there in the first place, we've not seen a change in our signature, therefore even in an IGRA positive patient they're unlikely to be bacilli, we don't need to continue this. So this is an interesting area of research, and this is something we're going to also do in TB Champ, because we've collected these samples. We've got these 4 very nice groups. We've got IGRA positive who are treated, IGRA negative treated. We've got placebo, IGRA positive who are treated placebo, and IGRA negative treated placebo. And I think it's important to have these different groups because levofloxacin is a broad spectrum antibiotic which does all kinds of things. And so we'll be disrupting, we'll be killing lots of other bacteria, and we'll be disrupting the host transcriptome in many ways. So you really want to adjust for those non-specific changes and really drill down into what are the impacts of killing MTB, and try and see what are the differences between the levofloxacin and placebo to try and identify whether there is a signature that's associated with the sort of death of mycobacteria, and see whether there are some IGRA positive children who actually don't really have a change in signature with treatment. That's more like a child who's IGRA negative being treated with levofloxacin, and those ones you might think, well, maybe they didn't have any bacilli in the first place, and potentially down the line you might not continue therapy after a short test after a period of time. So I'm going to stop there, and I'd be delighted to take any questions at all. I'll try and stop sharing somehow.
Thank you, James. Right, that was fantastic and such a huge amount of work, especially even just within TB Champ. So much going on as well. Thank you very much. Any questions? If you wanted to ask a question, please just either put your video on or just ask, or write them in the chat. Over to the floor. Can I start? I'll start you off, James. So, predictive scores that you're talking about, I just wondered from your perspective as both a clinician and a researcher, how much you thought we really needed gene signatures as opposed to, for example, looking at a child's nutritional status, HIV status, exposure, simple things that we can look for and measure as point of care that don't cost a huge amount of money. I just wanted to know if you know of any of the work that was ongoing with the gene risk signatures, if that's also, they've also looked at some of these factors alongside, or if there was any other work going on, what your opinion was of asking simple questions to try and identify risk.
No, look, I mean, I think there's a huge amount in that, and I think that we do need. I think people have looked at this, and there you can to some extent predict which children. I mean, the children who are HIV positive, children who are most malnourished, the youngest children. You still end up treating a lot of children. For those, you know, there are still a lot who don't, even in those categories, who progress to disease. But yeah, there are a lot of much more easily collected information which can help you stratify risk, absolutely, in children and in adults. And one of the pieces which I did mention, that this new WHO revised guideline is about diagnostics. That was one of the other PICO questions. And as part of that, we've developed an algorithm using purely clinical data to decide which children to treat for TB disease in presumptive TB cases. So using kind of approaches that you've also used in South America to try and make predictive signatures in these patients. You can do it, but my feeling is the biomarkers also aren't the whole picture. I think everyone wants a biomarker that is going to be the answer to everything, that will be perfect at discriminating either cases from controls or predicting future disease progression. But my feeling is that if you were to develop a kind of biomarker that was relatively cheap and was finger prick and could be used at a peripheral clinic as a point of care test, either as a lateral flow test or as a kind of gene expert type test, which, you know, increasingly are available, if they were cheap enough to be able to use, or you had funding mechanisms in place, I think we need to evaluate them as part of the algorithm. So you include data that is around their age and their HIV status and their nutritional status and their degree of exposure, and then you do the biomarker as well. And I think that on their own, the clinical type pattern is not sufficient, and I suspect the biomarkers on their own are also insufficient. But I kind of hope that integrating clinical data with biomarker data, you might get somewhere approaching giving the patients who really need therapy and not treating others.
Thank you very much. Any questions for James?
Tom, I've got a question. Sorry.
Please.
James, great talk. Thank you so much. I'm intrigued about sharing data between VCRIN and TB Champ. Clearly a good thing if both studies are a little bit underpowered. I'm wondering about the policy implications at the end of combining that data in one study that's predominantly adults obviously in East Asia, and another study that's in younger children in South Africa. Do you think there's enough generalizability to make a broader policy decision based on that combined data?
Well, I mean, it would be perfect if we'd done a trial in every age group in every country in the world, you know, but you never can do that. So you're always, when you're making guidelines, having to extrapolate, you know, what the data shows and how would it apply to a different population. And I think that by trying to integrate it from more than one site and more than one age group, hopefully we generate a bit more generalizability, but still there will have to be judgments made about is this really the same as a population in X, Y, and Z of a different patient group, post-transplant group in Belgium? I mean, I don't know. And we'll have to think about that, and people will have to make those decisions. I don't really have a great answer to that, but I think by trying to integrate these, we're trying to use as much data as we've got and use it as intelligently as possible, and rather than just summarize them, try and say how might the trial have done in Vietnam if we had a bit more information that could be borrowed from others. I mean, yeah. Afraid I don't have a clear answer for that.
Thanks. Jay, did you have another question? Jay, did you have any more questions? Did you have another question?
I can ask another one. I've got hundreds of questions always, but my other one, I guess, James, as a follow-on to that, is why have other clinical trials not done something similar? Because I get the feeling from the challenges of getting these clinical trials funded that there may not be a great deal of opportunities in the future to do follow-on studies in the same field. Why have other TB studies not combined and used Bayesian analysis to try and extract as much information as possible?
Yeah, I think there are probably a few reasons for that. I think one, I think it's a relatively new field, but please, other people who know more about this, jump in. I don't think there's a huge amount published about using these kind of approaches to inform clinical trials. I think the second part is there's always a lot of politics involved in this, and people don't necessarily always want to share results, combine results, etc. We've had really good relationships with the whole VQuin team the whole way through. We've all kind of served on each other's various committees. We've had regular meetings with them. We talked a lot to them about trying to align our case definitions, trying to make sure everything was follow-ups at similar time, things like that. I think the other component is I think this is quite unusual in that we are using the same regimens, both in the comparisons, and that I don't know many other TB trials that have really done exactly that, where you're comparing the same thing with the same thing. But I mean, there are a lot of preventive therapy trials probably that have done quite similar, but most of the sort of MDR TB therapeutic trials will use slightly different regimens, and so I don't know. I mean, you could probably include them in some Bayesian framework. There are probably people much better equipped than me on this call who have a much stronger maths background that could probably answer this. I'm looking at you, Pete.
I mean, possibly so. I'm sure it's not just about the maths, though. I mean, understanding what's appropriate to try and meta-analyze is as much as part of getting a sensible answer as bunging it in an appropriate technique.
Absolutely.
Thanks all. So are there any other questions for James? James, just in before, if anybody else throws one in, I just had another question. You alluded to it in your talk, but just for a non-pediatrician, monitoring for side effects and adverse events and things like when you use linezolid, for example, how do you do it? And how, we've all know about apps that are being developed for aminoglycoside for hearing loss and things, and I understand we're moving away from those, but I'm thinking of practicalities. How do you measure these adverse effects in children on a clinical or any other way?
Yeah, I mean, it's hard. I mean, it is veterinary medicine to some extent, the youngest children. I mean, you clearly have some things like blood tests that you have to do, and that's pretty similar between children and adults. There are complexities to getting the blood, and it's a bit more stressful, it's a bit difficult sometimes technically, but I mean, something like the hematological side effects of linezolid are not too tricky to monitor for, because that is a full blood count that you do, initially quite regularly, and then if you're fine, a bit less regularly. In terms of things like peripheral neuropathy, very hard. Things like visual fields or vision loss, very hard, and because the non-subjective ways of doing it, such as doing visual evoked potentials or doing peripheral nerve studies and things, I mean, just totally unfeasible in most contexts. So you are left with really just either children who are old enough to say something or parents' perceptions, and that's why I think it's really important to do these in a kind of blinded clinical trial way, because parents are quite perceptive on the whole. I think if they feel that their child is behaving differently in some way, in the way they're picking up objects, or they're crying a bit more, or they're saying their hands burn or something, or numb or funny, or using. I think for the youngest children under 2, it's very challenging. I think that even from kind of 2 or 3 onwards, though, children often articulate something which often parents can begin to understand, but very challenging. I don't have any ready answers for that.
Thanks, James. Okay, any other questions for James before we bring the meeting to a close in a few minutes? Any final questions? Okay, well, so James, just another virtual clap. Thank you very much. And Callum Selmpers was saying thanks for a great talk there in the chat. That was fantastic, and good luck with next week with the TB Union work, and good luck with TB Champ and all the other ongoing studies. I see Fernando Rubenstein is on the line. Hi, Fernando. And next month, Fernando is going to be presenting about his work in Buenos Aires. Hi, Fernando. Nice to see you. Did you want to just say hello, Fernando, just prior to closing?
Yes, hello to everyone, and thank you very much for this invitation. So Tom asked me to just comment on some of my line of work in TB in adults, mainly doing and evaluating different strategies for social support and better tuberculosis, specifically in Argentina, but probably something that may be transferable to other low and middle income countries. So some of those things I'll be commenting on, and now I'm just now running a clinical trial on a cell phone app for actual treatment support for those receiving self-administered treatment, and that's probably what I'm going to just focus more about what's going on with that trial, which has not been easy to do. Thank
you very much, Fernando. Thanks everyone for coming, and don't forget that it's the WHO symposium, which is free to access for anybody, on the new global TB report, October the 18th, European time, 12:30 to 3. I've put the link in the chat, and if any of you do want to be on our regular mailing list, please just send me a line. I'm at tom.wingfield@lstmed.ac.uk, and again, that's in the chat. Thank you. Tom Gorsuch, did you have a quick question?
No, I was just saying thank you very much. That's all. Good to see you, James.
Nice to see you too. It's been a very long time.
Oh, brilliant. Yeah, thanks, and a great turnout, and look forward to seeing you for Fernando's talk in November. Thanks very much.
Thank you very much.
Bye.